You can hear me now?
May I request Dr. Rai sir and Dr. P.N. Singh sir to please chair the session, sir,
Anand.
for Dr. Walsangkar.
Right. First, thank you very much for giving me this opportunity to speak to you. While this iPad is being connected, I'll try and talk to you through some common problems in neurology. See, I understand that this is a mixed crowd, so there are going to be physicians, pediatricians, ENT surgeons. So I just thought over what symptoms in neurology are common to all of the specialties. So I think anyone from a general practitioner to even the hepatologist cannot escape seeing a headache sometime in life. Second is dizziness. Third is epileptics, which can be a problem for all concerned because epilepsy associated with any other disorder is going to be difficult to manage. So what I'm going to do is to discuss our approach to headaches, only the common ones which everyone is likely to face: dizziness, epilepsy and stroke. So let's begin with headache. All of us in the outpatients will see a headache. The commonest ones first we try to distinguish all headaches into primary or secondary. As usual in medicine, primary or idiopathic is something we don't understand completely. Secondary is something where we find a structural lesion. The commonest primary headache we would come across is a tension type headache. I think ये बैठ जाएगा उसमें. So the commonest headache is primary. Let's think of, let's say someone sees a 45-year-old lady, several weeks of vertex headaches described more as heaviness or the pressure type associated with disturbed sleep. Most of the times these are tension type headaches, but there are certain red flags. If the headache is increasing in severity and frequency, whatever is the description, you have to be careful about excluding a structural cause. 90% of such description will turn out to be tension type headaches. So someone who has blurring of vision, number one, someone who has vomiting, and someone's headache is worsening over a period of time, that's an indication to do an imaging study. This is another common primary headache, migraine. I think all of us will have experienced this history sometime in life. Let's say a young man of 24, recurrent generalized headaches described as throbbing, lasting a day to 2 or 3 days, associated with vomiting. During the headache, many of them will have photophobia or phonophobia. Everyone will say, yes, this is migraine, nothing else. Now, which ones are the patients whom you need to investigate with imaging? Not all migraines need a CT scan or an MRI, especially if there is a strong family history, especially if there is a history of motion sickness, which is quite common in people who have migraine. So now, if someone comes with a migraine-like headache, but it is strictly unilateral, let's say only is on the right side, never changes sides, this is one person who should be imaged. Second is someone, as I said earlier, any headache with increasing severity and frequency will need imaging. And all of migraine patients will never have an abnormal physical neurological sign unless they have suffered a vasospasm infarct. So a normal neurological examination is mandatory in the diagnosis of migraine. But if they have focal weakness, any other neurological sign, you would image them because then you would like to exclude an underlying vascular tumor. People who have bruise either over the orbit or the carotids or the mastoid may turn out to have arteriovenous malformations. So usual history of migraine, but any of these red flags, all of these should be imaged. So what do we expect? We expect either a vascular malformation. What you can see in the top images is arteriovenous malformation. The black pipes, as called flow voids, which depict blood vessels of the arteriovenous malformation. The image on the right is a angiogram showing arteriovenous malformation. The bottom slide is a very vascular meningioma producing a throbbing headache, but again with a red flag. Now, these two are common headaches, tension type and migraine. But there are so many other varieties of headaches, it's impossible to finish them in a given period of time. But these two will take care of at least 60% of the headaches you'll see in OPD. So I think if you just concentrate on these two, and if you find it doesn't fit into any of these two, you can send it to someone who is going to look after headaches. Now, let's see someone, a middle-aged man, few months of lancinating pain of the face, unilateral, precipitated by chewing, speaking, and brushing his teeth. Standard classic history of a trigeminal neuralgia. Again, no abnormal neurological signs. What do we look for in trigeminal neuralgia? We look for abnormal eye movements, we look for facial sensory disturbance, we look for deafness, and facial weakness. So, neighborhood cranial nerves need to be assessed properly if you suspect trigeminal neuralgia. Let's say they're all normal. You would make a diagnosis of trigeminal neuralgia. If you have abnormal physical signs like deafness or facial sensory impairment, you expect to see a CP angle tumor on that side, whether it is a trigeminal neuroma or an acoustic neuroma. Even when there are no abnormal neurological signs, this is a common abnormality we would come across in trigeminal neuralgia. It's a vascular loop in the posterior circulation which abuts the trigeminal nerve, and the pulsations tend to produce demyelination over a period of time and trigeminal pain. So this is one investigation which would be useful in trigeminal neuralgia, even if there are no physical signs. If there are additional signs, you would expect to see tumors like acoustic neuroma. The right one is bilateral acoustic neuromas in someone with neurofibromatosis. So I think headaches, these three are the ones you can take care of in your OPD. Migraine, I think most of us are aware that we use, if they're very frequent, let's say 3 or 4 days a month they can't work, then you would want to give them prophylaxis with drugs like flunarizine, beta blockers, and valproate. These 3 drugs are commonly used. You should be aware, if you prescribe, let's say, flunarizine, you should be aware of what side effects to expect and explain it to the patient. Most of the times, flunarizine produces a little dullness, sometimes considerable weight gain, and in some people, what we call akathisia, so extrapyramidal side effects, where patients constantly have restless motor movements. So even with a suspicion of these motor movements, you need to stop the drug as quickly as possible, because they can remain persistent, what these are called as tardive dyskinesias, even if you withdraw the drug. So be careful when you prescribe flunarizine. Beta blockers, of course, you can't use with heart blocks and asthma. Valproate is commonly used. So these 3 are the drugs which we use for prophylaxis. And for an acute attack, we hardly ever use ergot. I'll tell you a story. When I started practice in 87, we used to use a lot of ergot alkaloids for migraine headaches. So there's a young girl who would have headache once every month or 2. I said, no prophylaxis, you can only use this drug as and when necessary. And the silly girl would take that drug every day for a period of 1 month. She had to have amputation of her index finger because of vascular problems. So we stopped using ergot and all of those derivatives since. Next, see the tension type headache I discussed earlier. There are two sorts of problems which present such headaches. Those who are depressed and those who are anxious. Those who are anxious generally tend to have bitemporal headaches, generally worse in the evening, and a good night's sleep generally reduces that headache. These are the people who will improve with anxiolytics, with diazepam or clonazepam. The other person with a tension type headache is depressed. He has a headache over the vertex, described as heaviness. The headaches are generally worse in the mornings, and by evening there is little improvement. And these are associated with early awakening. So these are the people where you would use antidepressants rather than anxiolytics. So I think that should take care of your day-to-day headache problems. Anything worse, you have to get a neurologist to see them. Next common problem, I think all of us, whatever specialty you are, is dizziness. And I'm sure everyone has come across someone with dizziness and never knew what was wrong with him. What happens is, the patient comes to you and says, chakkar yeti hai. That chakkar can have any meaning whatsoever. It has no meaning actually. So you have to go and ask whether this is a feeling of rotation, whether this is clouding of vision, and whether this is ataxia. Unless you are certain which one of these is the complaint, you can never actually go on the right track to make a diagnosis. So I think the first thing when I ask them when they're dizzy is, डोक्यात फिरतोय का, अंदर येते का, किंवा तोल जातोय का. Unless once make sure what you're dealing with. And once you are sure what you're dealing with, then you can go and ask the other questions which are necessary. So what's a vertigo? Vertigo is a feeling of rotation, either objects or yourself rotating around yourself. This is associated with significant autonomic disturbance like profuse perspiration. Some people will have vomiting, some people will have loose stools, and in some people the sensation is so intense that they develop bradycardia and fall down. So it's an autonomic disturbance which is quite common with vertigo. I think there are three major sort of categories you can distinguish when you come across someone with a vertigo. One is peripheral, and if you think of a common disease, Meniere's is the one with peripheral vertigo. Second most common is paroxysmal positional vertigo, and third is some sort of a brainstem or posterior fossa pathology. Now, Meniere's disease is the prototype of a labyrinthine vertigo. What does it present with? Episodes of rotatory vertigo, vomiting, and during the time of vertigo they would be ataxic. This resolves over a period of an hour, 2 a day. They are back to normal. Some people are left with some sensation, mild sensation of unsteadiness. This is associated with tinnitus and progressive deafness. As the deafness progresses, dizziness gradually diminishes. So I often tell my patients, be lucky and get deaf quickly so that the dizziness stops. But that's the story of Meniere's disease. Investigation, not much to be done unless you find significant signs. You would do audiometry, imaging if you suspect a CP angle tumor. Treatment-wise, there is not much to be done, but commonly we use beta-histine on a long-term basis, and other drugs like cinnarizine, cyclizine, meclizine. If the vertigo is intractable, you do have some surgical procedures like labyrinthectomy. So you can have injection of gentamicin within the inner ear. So there are other very specialized procedures which you need not worry about. Only about 1 or 2% of such people will need those procedures. So most of them can be managed by these drugs or sometimes Dimox. Now, this is a vertigo I'm sure all of you have seen, but none of you have thought of this disorder. This is very, very common, especially after trivial head injury. Many people will say, oh, I'm terribly ill. I have rotatory dizziness. The moment I get up, I become dizzy. The moment I lie down, I become dizzy. When I turn from side to side, I become dizzy. It lasts about a minute or two, goes away, but they become extremely frightened because of vertigo. And there is no tinnitus, no deafness, and positional test is generally positive. Look at this video, it's an animation. Maybe you'll be able to. Oh, it's slow motion. It's not coming back, I don't know. And I'll show it to you once it's on, not moving. So what you do is ask the patient to sit up, turn the neck to one side, extend it, make them lie down. Within a few seconds, they will start complaining of rotatory dizziness, which will last about 30 to 40 seconds. Then they will have a rotatory nystagmus. Goes away in 30 seconds. You make them sit up, they again have a similar vertigo, but the direction of nystagmus reverses. So that's characteristic of a benign paroxysmal positional vertigo. Once you confirm that this is so, make them lie down in the same position. Ask them to turn exactly in the opposite direction. Make them lie down for a minute with the head towards the ground. And that completes your Apley's maneuver, and you can cure about 60% of patients with this maneuver. Nothing needs to be done. But you have to be confident that this is positional vertigo. You should not miss a stroke for a positional vertigo. We'll come to that a little later. So, vertigo brought on by change of position of the head, no tinnitus, no deafness, no other neurological signs, positional test positive. If that is so, you can be confident it's a paroxysmal vertigo. No investigations are necessary. And a positional test done will confirm it. And you can reposition by asking them to lie down in the opposite direction for about a minute with a head drop. That cures, I think, 60% of people. The rest of them need to just practice what is called Brand Arrow exercises. You can go to the YouTube and see many videos which demonstrate this. Now, the next important thing which can be a disaster is missing something in the brainstem. So, earlier many years we have seen recurrent episodes of vertigo, tinnitus, deafness. Paroxysmal vertigo lasts 30 to 40 seconds, only brought on by a certain position of the head. Again, in both of these, there are no neurological signs except for some deafness in Meniere's disease. But with brainstem or posterior fossa lesions, you can have lots of physical signs, sometimes no signs, but you can miss a major lesion. So, what do you have to be careful about? Someone who comes to you with vertigo, but also says that he's a little bit unsteady when walking. He may have neighborhood signs like difficulty swallowing because of cranial palsies. He may have cerebellar ataxia because it is neighborhood. And especially if it is acute, you have to be absolutely certain that you are not dealing with a stroke or a brainstem hemorrhage. So, someone who comes to you with sudden onset of vertigo for the first time in life, has no tinnitus, deafness, and may or may not have some signs, you should investigate him for a major disaster like a basilar artery occlusion or posterior circulation stroke. So, first two you are clear about. Something which doesn't fit into first two you should investigate. That's all you need to remember, because not everyone is a specialist, I can understand. So, try to remember the first two. If it doesn't fit into those two, get him investigated. So, you're sure what you're dealing with. So, that's an MR demonstrating a pontine infarct. And this is a childhood brainstem glioma. You can see expansion of the brainstem and the white blob within the brainstem, which is a cystic lesion within the brainstem. So, I think as far as vertigo is concerned, if you just remember the first two disorders, make a proper diagnosis. And in your mind you should be sure it is not the first two, get him investigated. You will not miss anything major and you will not have a disaster on your hand. Epilepsy is a disorder not everyone may be treating, but you need to be aware of certain problems related to epilepsy because they impose on all other specialties. You want to do a mastectomy and the patient is epileptic, you will go and call a neurologist. Should I do it or not? So, try to understand a little bit so that how it impinges on your specialty you will understand. Let me define certain things. Seizure is an electrical brain abnormality causing either a convulsion or a non-convulsive seizure. Convulsive seizure is where you actually see with your eyes bodily movements associated with the seizure. Myoclonus, everyone knows what a myoclonus is? No. It's a sudden bodily jerk. Like a child with a loud noise show startle. Exactly the same. That's myoclonus. Why is it important to ask questions about history of myoclonus? Is because if patients have myoclonus plus seizures, the drug of choice is valproate. It's so easy to practice. And last is absence, where there is only lapse in concentration without any loss of bodily tone or any bodily jerks. So with this, I think there are about 10 physicians I just told. So I'll explain to you a little bit more about what do we do when we come across epilepsy. Out of 100 referrals for epilepsy evaluation, 2 turn out to be pseudoseizures. So that's the first thing you should be sure about. When someone comes to you with an episode of, let's say, fall, a loss of consciousness, bodily jerking, just make sure that this is epilepsy. Do not start any anticonvulsants. Because out of 100, 2 to 3 will turn out to be pseudoseizures in at least my practice. So to be sure, make sure that you get a history of at least tongue bite with some bleeding, incontinence, because this would be very, very uncommon with a pseudoseizure. And depending on the type of epilepsy, you may have bodily jerking, you may not have bodily jerking. So that's depending on the type. So generalized seizure, we all know, begins with an aura, epileptic cry, tonic posturing, hypersalivation, cyanosis, incontinence. Then clonic jerking, lasts about a few minutes, recovers, he may have postictal vomiting or behavioral disturbance. That's the standard generalized seizure. If you have only a focal seizure, which could be either motor or sensory, so you have unilateral sensory disturbance or unilateral jerking, a focal seizure, and a temporal seizure can only manifest as a behavioral abnormality lasting minutes. Myoclonus, I just discussed earlier. Absence you can induce in your OPD by hyperventilation. Generally common in younger children between 5 to 15 years of age, and most of the times the presentation is, this child doesn't listen to me, they do not have attention. No one will tell you that they have some eye blinking during this time. Especially if you look at their notebooks from school, in the middle of a sentence they'll keep on writing the same word, miss a few words, start writing again. So only for a few seconds they have a lapse in concentration. You make them sit, make them hyperventilate, and within a second they'll just stare at you for a second, goes away. So if you see this after hyperventilation, get an EEG done. EEG is abnormal in about 80-90% of absence seizures, not other types of seizures. I think investigations, all of us are aware that we do either CT and MR for the first time epileptic, electroencephalogram. See, this PBG, porphobilinogen, costs you about 10 or 15 rupees, urine examination. Do it every time. The reason is, you are going to start either phenytoin, phenobarbital, carbamazepine, and all of these will induce an attack of porphyria. So before you start any of these 3 drugs, make sure that urine PBG is negative. That doesn't necessarily exclude it, but it's useful 80-90% of the times. Now, once, let's say, we have investigated the patient thoroughly, he has a generalized seizure, and now we have to decide whether we should initiate treatment or not. What are the points on which we first decide whether treatment should be started? Number 1, a single unprovoked seizure. Some people would say, don't wait, don't start any anticonvulsants. A provoked seizure, by provoked seizure I mean high grade fever, hypoglycemia, or sleep deprivation for a day or 2 can induce a seizure in susceptible individuals. Such people need not necessarily be initiated on day 1, but there is a lot of difference of opinion about this. It depends, especially if you see a structural lesion on CT or MR, you would start anticonvulsants without any thought. But normal EEG, normal CT or MR, and a single seizure, there is still a problem. Number 1. Number 2, the type of epilepsy will also decide what drug you choose. Let's say someone comes to us with primarily generalized epilepsy, no focal onset. The drugs we can use are carbamazepine, oxcarbazepine, valproate, levetiracetam. So these three are the drugs we can commonly use. Let's say someone has generalized epilepsy plus myoclonus, as I said earlier. The drug of choice would be valproate. The second problem comes is if this person is a young woman in a childbearing age, I would avoid valproate. The reason is it has the highest incidence of fetal malformations. So the choices you make depend on so many things and they have to be individualized. So gender is a great concern. I would not use phenytoin in a girl because they have coarsening of skin, they grow facial hair. So avoid certain drugs in women because of their side effects. Second is, what duration do you normally recommend? Recommendations are a seizure-free interval of 3 to 5 years, depending on type of epilepsy. Now let's take example of benign focal epilepsy of childhood. Normally it occurs between the ages of 5 and 15, and after 15 it dies away. So such people, we would generally recommend treatment until the age of 15 years and then taper off. Second thing is, you should always be aware of what side effects to expect from a particular drug. So make sure that you use only few selected drugs and you are quite friendly with the drugs. You should know everything about the drug. So if I prescribe oxcarbazepine, the first thing I tell them is you might develop allergy in 2% of people. If that happens, come back to me. If you don't, you are in trouble. So use only a few drugs. Know everything about them. You need not know everything about all drugs. It's no point at all. But it's very important to know the side effect profile. Preference is to use a single drug in a maximum possible dose. If that doesn't work, only then add a second drug, not otherwise. Now, there are common factors which will precipitate a seizure. Number one, sleep deprivation. Strongest stimulus for a seizure. So, regular hours of sleep are important. Missing a meal, you can also have a seizure. Poor compliance, I think that's the commonest cause of recurrence of seizures. And swimming, driving, and other potentially hazardous activities, you should make them aware what's going to cause a problem. So we cannot describe all activities which should be careful with. It's common sense. So you need to tell them what can happen. Don't use machinery with flying parts. So simple things. This is especially useful for gynecologists. Epilepsy and women. Certain anticonvulsants will interact with oral contraceptives, reduce the effectiveness of oral contraceptives, especially phenobarbital, carbamazepine. So be careful when you use oral contraceptives in people with epilepsy. Secondly, contraceptives in some epileptics will increase the incidence of seizures. If that happens, you have to choose a different method. Catamenial epilepsy or perimenstrual seizures are common, especially myoclonus, and for such people we recommend Diamox about 8 to 10 days prior to menses and a few days later. This is a very touchy subject, pregnancy and childbearing. Now let's say a young girl comes to you about 22 years of age, she has epilepsy, needs, let's say, lifelong drugs. What should our advice be? Number one, you have to choose a drug which is effective, which is going to control seizures and least likely to cause fetal malformations. So there's so many malformations that have been described, but the newer anticonvulsants are much safer, so you can fairly safely recommend them. So the ones described are spinal dysraphism, cleft palate, limb reduction, cardiac abnormalities, hypospadias, GI atresia. Most of these occur because of folate problems, ischemia, reactive intermediates of drugs, and certain genetic susceptibilities. Now, drugs with which malformations are described the most are phenytoin, carbamazepine, valproate, and phenobarbital. So these are the drugs I would avoid. The newer drugs which are recommended to be safe during pregnancy are levetiracetam, lamotrigine, and oxcarbazepine. So choose one of these drugs. and keep them at an appropriate dose level. As weight gain occurs during pregnancy, you may have to readjust the dose. Add folate supplements, and for God's sake, during pregnancy, do not recommend to stop drugs. So this happens at least 2 or 3 times a year. Someone is absolutely well controlled on a safe drug, on folate supplement. After 2 months of pregnancy, the idiot goes to someone and a neighbor tells them, dawa mat le lo, takleef ho jayegi. They stop drugs, come back to you with status. So as their physician, always recommend to them that do not stop drugs. A major seizure they can abort. So make sure that they continue to take drugs regularly. So before conception, if there is a young girl coming to you with epilepsy, before conception, make sure that she is on a safer drug. Add folate supplement. Keep it at an appropriate dosage level. With weight gain, you may have to increase the dose. So make the pregnancy safe. And the incidence of fetal malformations with your newer drugs is even less than 3 or 4%. So you can make them, reassure them and say that you need to take these drugs during pregnancy. How much time do I have? 5 minutes? Okay. Now this is one topic which I think all specialists should be aware of. See, what's happened is, about stroke, everyone has been so negative. Ye ho gaya, isko gaya bhi. That's how the attitude was. But with good thrombolytic drugs and now interventional procedures available, you can have a very good outcome even in a major disastrous stroke. So the moment you suspect a stroke, make sure that they go to an appropriate center for proper treatment. I'll not go into details, but it's basically disease of blood vessels causing dysfunction either of the brain, spinal cord or the eye. That's a stroke. So anything which happens suddenly to the brain or to the eye or to the spinal cord should be assumed as a stroke unless proven otherwise. So acute hemiplegia, acute loss of speech, acute facial asymmetry, acute tingling, all of these acute behavioral problems because of temporal lobe infarcts, all of these should be regarded as stroke, especially if they are acute. Someone was all right a few minutes ago, is disabled, likely to be a stroke. Whether it is a bleed or ischemia, investigations will tell you. I think you're all aware of what the symptoms are. Hemiplegia, facial weakness, sensory disturbance, acute ataxia, vertigo, vomiting, loss of consciousness, posterior circulation strokes. Important thing to remember is sudden onset of headache is also a bleed, subarachnoid hemorrhage unless proven otherwise. So sudden headache, vomiting and neck pain, patients can come to you walking. Do not assume that bleed always means loss of consciousness. So many patients come to OPD with headache and vomiting. This is one other thing I want you to be aware of. See, transient ischemic attack up until now was regarded, okay, 5 minutes ho gaya, theek ho gaya, give antiplatelets and go home. But if you assess them properly, you can actually predict who is likely to have a stroke. What are the risk factors? So if you have what we call an ABCD score, so anyone more than 60 years, anyone with hypertension, anyone who had a clear focal weakness or speech disturbance and symptom duration of more than 10 minutes has a high risk of recurrence and a high risk of a stroke, so he needs to be evaluated as soon as possible. So just think of a few factors: age, blood pressure, deficit and duration. So any of these are significant, don't delay, they can have a stroke. Now I'll tell you, just give you brief 2 cases, what can happen with appropriate treatment. I'll tell you, for thrombolysis, out of 100 strokes, about 2%, not even 2 to 3% of thrombolyze. So 97% of strokes do not get any treatment. The reason is half of our population and also practitioners are unaware that there is a treatment available for stroke. So 53-year-old man, acute dizziness, tingling left side, double vision, unsteadiness of 2 hours duration, blood pressure 170/100, dysarthria, internuclear ophthalmoplegia looking to the left, right ptosis, left cerebellar ataxia, could not walk. So blood's normal, MR absolutely normal, so diffusion images, which means that he has ischemia but no infarct. So salvageable brain tissue. Angiogram also normal. So measurable deficit within 3 hours, TPA given, complete recovery over the next 3 hours, no recurrence. This was done 8 years ago, he is perfectly normal still. One more young man of 24, antiphospholipid positive, treated earlier for a stroke, stopped treatment, usual. About 2 p.m., acute left-sided weakness, static. 4 p.m. became decerebrate, 6 p.m. became obtunded and was unconscious. He had poor dorsal eye movements, decerebrate to pain, had to be intubated, was on a ventilator. CT head scan normal. MRI, if you look carefully, there is a small white dot to the right side of the pons. That's the only area of infarct. But he is completely unconscious, which means his whole of the brainstem is hypoperfused. So he is a disaster. No basilar artery seen, both carotid seen, complete basilar occlusion. So out of window period more than 3-4 hours, so no IV thrombolysis. So we did an angiogram, intraarterial thrombolysis for this young man. So this is a vertebral injection. You can see that beyond the mid basilar nothing else is seen. So after a microcatheter manipulation, we gave him intraarterial thrombolytic agents, TPA, and within about 20 minutes it recanalized. And this is the angiogram after thrombolysis. So except for the left superior cerebellar artery, everything is revascularized. So he now attends college, and except for sometimes uncontrolled laughter, he is back to normal. So stroke can be treated properly. You have to be aware that this is a stroke and get him to a proper center as soon as possible. That's what you need to do. And the patients will thank you all their life for saving disability. Thank you very much for your patient listening. I hope I've done something useful to you.
Thank you so much, sir, for the wonderful, informative presentation for all of us. May I request, I'm not going into question answers due to
please
lack
don't.
of time.
Because we are already late.
Thank you, sir.
Okay.
I would request Dr. Rai, sir, and Dr. Singh, sir, to please present a small token of love to Dr. Walsangkar. May I request Rao, sir, to please hand over a small token to our beloved Rai, sir, and Singh, sir.